Welcome to Obstetrics and Gynecology Made Easy. In today's video, we'll explore an essential mnemonic to help you remember key hemostatic drugs used in the management of postpartum hemorrhage. Hemostatic drugs play a significant role in preventing and treating postpartum hemorrhage. This mnemonic, Comfort, highlights essential medications and their evidence-based recommendations from leading medical organizations, including the American College of Obstetricians and Gynecologists, or ACOG, and the Royal College of Obstetricians and Gynecologists, or RCOG. Mnemonic. Comfort. C. Carbadocin. Evidence-based medicine. Carbadocin has been shown to reduce the need for additional uterotonics in cesarean deliveries, with a longer duration of action compared to oxytocin. American College. Carbadocin is not routinely recommended but may be considered as an alternative to oxytocin, especially for cesarean sections. Royal College endorses carbadocin as a long-acting alternative to oxytocin for postpartum hemorrhage prevention in cesarean deliveries. Dosing. 100 micrograms IV as a single bolus after delivery. O. Oxytocin. Evidence-based medicine. Oxytocin is widely supported by clinical trials and meta-analyses as the first-line uterotonic for preventing and treating postpartum hemorrhage, promoting uterine contractions to reduce blood loss. American College. Oxytocin is recommended as the first-line agent for preventing and treating uterine atony after delivery. Royal College recommends routine use of oxytocin, 5 to 10 units IV or IM, during the third stage of labor to prevent postpartum hemorrhage. Dosing. 10 units IM or IV bolus, or 10 to 40 units in 1 liter of IV fluid for infusion. M. Misoprostol and methyl ergometrine. Misoprostol. Evidence-based medicine. Misoprostol is less effective than oxytocin but remains valuable in postpartum hemorrhage, particularly in low-resource settings where oxytocin may not be available. Studies show higher rates of side effects, such as fever and chills, compared to oxytocin. American College. Misoprostol is recommended as a second-line agent in postpartum hemorrhage, particularly when oxytocin is unavailable or ineffective. Royal College recommends misoprostol for postpartum hemorrhage in resource-poor settings or where refrigeration and IV administration of oxytocin are unavailable. Dosing. 600 to 1,000 micrograms rectally or orally for postpartum hemorrhage. Methyl ergometrine. Evidence-based medicine. Ergometrin is effective but has limited use due to side effects like nausea and hypertension. It is often used in combination with oxytocin. American College suggests using ergometrin as a second-line agent in postpartum hemorrhage when oxytocin alone fails but should be avoided in women with hypertensive disorders. Royal College recommends the ergometrin-oxytocin combination, also called sintometrine, for postpartum hemorrhage but notes its contraindications in hypertensive patients. Dosing. 0.2 mg IM or IV for postpartum hemorrhage. F. Fibrinogen concentrate. Evidence-based medicine. Low fibrinogen levels are associated with increased bleeding risk in postpartum hemorrhage. Early fibrinogen replacement improves outcomes in massive hemorrhage. American College. Fibrinogen concentrate is recommended when fibrinogen levels fall below 2.0 grams per liter in the setting of massive obstetric hemorrhage. Royal College recommends fibrinogen replacement, either by fibrinogen concentrate or cryoprecipitate, in severe postpartum hemorrhage with evidence of low fibrinogen levels. Dosing. 2 to 4 grams IV, based on fibrinogen level monitoring. R. Recombinant activated factor 7 (RFVIIA). Evidence-based medicine. While not widely studied in large trials, case series, and observational studies suggest that RFVIIA can be life-saving in severe, refractory postpartum hemorrhage unresponsive to standard treatments. American College recommends RFVIIA only as a last resort in life-threatening hemorrhage after other interventions have failed. Royal College similarly suggests RFVIIA as a last-line therapy for severe hemorrhage when standard treatment is ineffective. Dosing. 90 micrograms per kilogram IV bolus, repeat as needed. T. Tranexamic acid. Evidence-based medicine. The woman trial showed that tranexamic acid significantly reduces mortality from postpartum hemorrhage when administered within 3 hours of onset. American College recommends tranexamic acid for use in postpartum hemorrhage, particularly when bleeding continues after uterotonics, like oxytocin, have been given. Royal College advocates for early use of tranexamic acid in postpartum hemorrhage within 3 hours of delivery, based on woman trial results, and also recommends it for heavy menstrual bleeding. Dosing. For postpartum hemorrhage, 1 gram IV over 10 minutes, repeat if necessary. For heavy menstrual bleeding, 1 gram orally, 3 times a day during menstruation, with a maximum of 4 grams per day. Conclusion. Both ACOG and RCOG align with evidence-based medicine findings, recommending the early and appropriate use of these hemostatic drugs in managing uterine bleeding, particularly postpartum hemorrhage. Oxytocin remains the first-line therapy across all guidelines, with tranexamic acid recommended early in postpartum hemorrhage management. Misoprostol is preferred in low-resource settings, while specialized drugs like carbadocin, RFVIIA, and fibrinogen concentrate are used in specific circumstances or severe cases.